Hello, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I am pleased to welcome you all to another live session, and this is titled Sleep Health and Fatigue Management. We often get questions related to these topics, so I'm very happy to bring this presentation to you today. Just before we start, I want to go through a few housekeeping items. Like always, this Zoom software does not allow you to access your camera or your microphone, so if you do have a question, please be sure to enter it in the chat at any time during the presentation, and we'll be sure to get to the questions at the very end. And with that said, to introduce our speaker today, we have here Catherine Ann Pidaloo, who is a Doctor of Psychology student at Memorial University in Newfoundland, working under the supervision of Dr. Sheila Garland. She earned her Bachelor of Arts in Psychology with a minor in Religious Studies from the University of Calgary. Following her undergraduate studies, Catherine Ann continued her research in psychosocial oncology at the Tom Baker Cancer Center, co-authoring several published papers on integrative oncology approaches. So thank you, Catherine Ann, for joining us today, and you can get started as soon as you're ready.
All right, sounds good. Well, thank you everyone for having me here today. As mentioned, my name is Catherine Ann. I'm a Doctor of Psychology student from Memorial University in Newfoundland. So today we'll be talking about sleep health and fatigue management. Okay. So just an overview of some of the things we'll be talking about. We'll be talking about cancer-related fatigue, the relationship between fatigue and sleep, what regulates our sleep. So if we can better understand what regulates our sleep, we can kind of find ways to kind of improve it throughout the way. We'll talk about when sleep goes wrong and what we can do with treating those sleep difficulties. And then I've provided a lot of sleep rules or like tips and tricks for you to take away and hopefully try even this evening with some added resources as well. And then we'll have some time for questions at the end. So some of these slides and the information in it have been adapted from my supervisor, Dr. Sheila Garland. Okay, so first off, defining cancer-related fatigue. So there's a definition for it, and it's referred to as distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. So a little bit of facts about cancer-related fatigue. Well, it's estimated that 40% to 90% of individuals with cancer will experience chronic fatigue. It tends to vary again based on cancer type, stage, treatment, and how the fatigue is being measured in these studies. Specific to lymphoma, it's estimated that 72% of individuals will report fatigue to the level of it impacting their functioning. So some of the symptoms may include difficulty thinking, physical exhaustion, lack of feeling rested even after a night's of sleep. Okay, so the relationship between fatigue and sleep, well, as I just mentioned, sometimes sleep doesn't always improve the cancer-related fatigue, but poor sleep qualities or sleep difficulties or even sleep disorders can contribute to increased feelings of fatigue throughout the day. So with that in mind, knowing that, sleep doesn't necessarily help in terms of treating the cancer-related fatigue, but having poor sleep can greatly impact how we're experiencing our fatigue throughout the day. It can be really helpful to kind of look at our sleep and what's going on in it, since that's somewhere that we could maybe intervene. So when we think about what regulates our sleep, there's two processes kind of at play here. So our first one is something we call our sleep drive or sleep pressure. So our sleep drive naturally increases throughout the day. So the more time that we're awake, the more tired we're going to feel. And this is largely kind of driven by adenosine, which is a neuromodulator or chemical in our brain that accumulates the longer we're awake. So the more we're awake, the more tired we're going to feel. And then at night, when we go to sleep, that adenosine starts to diminish in our brain, which will help us feel less sleepy. So this process is very similar to another process in our body, such as hunger. So the longer we go without eating, the more hungry we're going to feel. Same thing with our sleep. So with this kind of process, there's a way we can use our sleep drive to our advantage. So there's actually a math equation that we can do. So if you wanted to take out a pencil and maybe try this along, there's a way that we can kind of calculate what should our prescribed bedtime be based on what our current sleep ability is. So in order to do the math, we'll take how long we're typically sleeping. So for this example, I have 6 hours here. So if you're sleeping 6 hours a night, go ahead and put that down. If you're sleeping 8 hours, go ahead and put that down too. Then for the next number, you're going to put what time you want to wake up at. Okay, so not what time you normally wake up, but maybe what time you'd like to be getting out of bed. So for this example, I was overconfident, I guess, with the 7 a.m., but 7 a.m. is the time that I maybe want to get up every morning. So what we'll do then is we'll subtract our sleep duration from our wake time. So in this case, it's 1. So this is our prescribed bedtime. So that means we'll go to bed at 1 a.m. and wake up at 7 and get that hopefully 6 hours of sleep. So what this means in terms of our sleep drive is now we're giving ourselves 18 hours of that sleep pressure to kind of build up throughout the day. So there are some things that we do, and it makes sense that we do them sometimes, that actually weakens our sleep drive. So this can be spending excess time in bed. So oftentimes, when we are feeling very fatigued, we want to rest, and sometimes that natural place to go is our bed. But by spending that extra time in bed, we're actually decreasing our sleep drive, which is going to make it more challenging for us to go to bed when we are ready to sleep. Next on that list is napping, especially too close to dinner time. So if we think back to that process of hunger, if we were to have, a little snack before dinner, we're probably not going to be as hungry by the time dinner rolls around. Same thing with our sleep. If we nap right before we're going to go to bed, we're not going to be as tired. Dozing off is another one too, and sleeping in on weekends. So with sleeping in on weekends, what that does is that kind of decreases that time that we're awake. So if we think back to that 18 hours that we're awake, if we sleep in, we kind of cut that time even smaller and smaller. Because what ends up happening is we end up going to bed at the same time that we always do, but we haven't given our body enough time to build up that sleep pressure. Next process we have is our circadian rhythm, which can be kind of referred to as our body's internal clock. So as our internal clock, it helps regulate several different processes in our body, one being sleep, also eating, our body temperature, cell regeneration, hormone production. It's really is kind of cycles through a lot of different processes in our body. And it coordinates very closely with the day and night cycle. So there's a few things that we can do also to help strengthen our circadian rhythm or our internal clock. And this is waking up and getting out of bed at a regular time. This is actually one of the strongest anchors for our internal clock, is having that consistent wake up time. Next is the timing and the amount of light exposure. So this process here really gets at that hormone production. So melatonin, our natural sleep promoting hormone, is produced in the absence of light. So when light isn't present, that's when melatonin is being produced. So we can start to be really strategic with some of our environment to kind of help trigger this process in our body. So for example, at night, kind of giving yourself some time in dim lighting before going to bed, avoiding any bright light screens, overhead lighting, maybe turning on a side lamp instead, can all be helpful of ways of kind of cueing our body for sleep. Now, on the other side of that, in the morning, getting that light exposure kind of first thing can be really helpful too, of kind of cueing the body that, oh, it's time to be up, because it will start to diminish that production of melatonin as well. And the last one there is the having like routine around exercises and eating. Okay, so what about when sleep goes wrong? Well, there's a number of different factors that can contribute to this, but oftentimes, more than not, it can be our arousal system. So this is when we go to bed for some reason when our brain decides to be kind of the loudest. So just a little cartoon here. So, okay, let's revise some of that dumb stuff you said today. This could take a while. Then another hour later, oh, just quickly, remember that argument from 6 months ago? And we're still thinking about it. And then another hour passes and you're kind of like, oh, like what now? What could I possibly be thinking about now? Oh, well, you're going to look really tired tomorrow morning. So this is kind of our arousal system that promotes that wakefulness in bed. Oftentimes this can be, you know, thinking about an upcoming appointment, thinking about an event you may have to go to, running through kind of like the what ifs of our day or the what ifs of the future of what could happen. This is all our arousal system at play. And it makes sense that sometimes our brain is the loudest at night because that can be the only time that we may be kind of by ourselves and quiet. The rest of the world is quiet, so the brain tends to get the loudest. And what happens when we spend that time kind of thinking in bed and being more awake in bed is we start to condition ourselves to be awake in bed. So rather than sleeping in bed, we get used to the idea that our bed is the place for thinking or for trying to solve all these problems. And what can ultimately happen over time is that this arousal system kind of continues to win throughout the night. We can see it develop into something like insomnia. So how do we define insomnia? Well, the severity of insomnia can range. So it can be that occasional poor night of sleep, or it could be like a reoccurring weekly or several times a week, and persist for up to 3 months. That's where we get more into that insomnia diagnosis. So how are we defining insomnia disorder? Well, it has to do with the dissatisfaction with our sleep quality or quantity, and is really kind of characterized with difficulties with either initiating sleep. So if it takes, you know, kind of longer than 30 minutes to fall asleep, could be maintaining sleep, or having some early morning awakenings kind of before our alarm or earlier than what we would like to see. And again, it's happening, you know, anywhere between 3 times per week up to, you know, 3 months or longer. And usually insomnia is also accompanied with distress, some impairments in daytime functioning, such as irritability and that fatigue. So coming back to that cancer-related fatigue and sleep difficulties, you know, some of the consequences of insomnia are very similar to those of cancer-related fatigue. So specifically within the cancer population, you know, anywhere between 30 to 50% of cancer patients kind of report difficulties with insomnia. Again, varies kind of on cancer type and time of assessment. But the reason I pose this number is because if you look at it in the general population, it's only 10 to 15%, which is quite a big difference between the 30 to 50%. So what's the big difference there? Well, it can be, you know, the increased prevalence of anxiety and/or depression. Chemotherapy has also been associated with disruptions in our circadian rhythm. Some medications also can disrupt our sleep. Hormone treatments and other factors, again, such as fatigue, pain, and discomfort, all kind of contribute to potentially the development of insomnia. So again, kind of looking at it specifically with fatigue. So in this meta-analysis study, it looked at a total of 84 studies and kind of pooled all the data to look at any potential risk factors that could increase the odds of developing cancer-related fatigue. So if we look on this chart here, we see the insomnia down in that red box. The odds ratio is 2.83. Okay, so that means that people with insomnia are 2.8 times more likely to develop cancer-related fatigue. And this other one here is depression. So people with depression are 2.2 times more likely to develop cancer-related fatigue. Now, there are other ones on that list here, but I point those ones out because those are the ones we might have, you know, a little bit more control over. So yes, that can be really challenging to try to get those under control, but they're a little bit more manageable than maybe some of the other ones on this list, like being female or the type of treatment that we're receiving. So when we think about the things we want to try to manage, we want to make sure that they're kind of tangible and things that we can manage, such as the poor sleep difficulties. So if that's the case, if we can manage it, then how exactly do we do that? But based on clinical guidelines from the American College of Physicians, they've recommended cognitive behavioral therapy for insomnia, also known as CBTI, kind of the first line of defense for treating insomnia disorder. So that's there on that first recommendation. And if you look at the second one, it kind of suggests us too that the CBTI is actually can be more effective than just pharmacological therapy alone. Okay, so this is the 3P model of how that development of insomnia can occur. So what we have on the bottom here is kind of a timeline. So 1 to 2 weeks, 2 to 3 months, and then greater to 3 months. And then if we consider this side here as our insomnia threshold, so anything over the line would contribute to the development of insomnia, and anything below would be considered maybe not insomnia. And these up top here are some factors that can contribute to it. Okay. So this first one here is we have our predisposing factors. So our predisposing factors are things that we can't necessarily do anything about or change, and they're consistent throughout time. So an example of this could be family history of sleep difficulties. It could also be, unfortunately, just being female also increases kind of the chance of developing insomnia. Doesn't necessarily mean we will get insomnia, but it's again one of those factors that could contribute to it. This could also be someone who's maybe naturally more anxious or stressed, stress-related traits. Again, doesn't necessarily contribute to insomnia, or sorry, push you over the threshold of insomnia, but could contribute to it over time. So again, it's consistent throughout time. Next, we have our precipitating event. So this is something that, can occur. It could be a single event or it could be multiple things. But 75% of people with insomnia can kind of identify a single event that kind of push them over the threshold, at least immediately, for developing insomnia. So a lot of people report, when they're receiving their cancer diagnosis as kind of pushing them over that insomnia threshold. It could also be starting treatment. It could be the combination of it all too. But again, our body will naturally kind of adjust over time and bringing us back down that insomnia threshold. Next, we have our perpetuating factors. So these are things we naturally do to kind of initially combat our sleep difficulties, such as, staying extra or spending extra time in bed, napping, sleeping in on weekends, resting in bed, all may help in the short term, but again, contribute to it over time. Now, the last factor here is our conditioned arousal. So that is our wakefulness in bed, the thinking in bed, the running through our to-do list, thinking about an upcoming appointment, thinking of all the things we need to do the next day. Those are all things that really contribute to that conditioned arousal in bed. And again, what we end up doing is we end up pairing our bed with that feeling of wakefulness. So when we go there, we naturally are going there to think rather than to sleep. And this is the biggest factor that contributes to that insomnia over time. Okay. So for some takeaways of some sleep rules, I have a couple of them here, but if I was to maybe sum it up into 3 arching kind of themes, the first one would be, really strengthening that relationship between your bed and sleep. So taking all sorts of activities out of there, keeping your bed for sleep and sex. So lots of people tend to relax in bed when they're not feeling well or if they're feeling tired. So that may be, kind of looking at other places in your home where you can go to relax, or you can go read your favorite book or scroll on your phone or watch a show. It's really about, taking those activities outside of your bed and finding somewhere else in your home. So it's not that you can't do them, it's just finding somewhere else to do those activities. And the next one there is building a routine. It can be really helpful to have that consistent wake time. Our body really does like that consistency. And then listening to your body, sleep when you're tired. So if you are feeling that need for sleep, then definitely listen to your body. And maybe not going to bed when you're not feeling tired, or just because oh, it's 11, I should go to bed now. It's more that checking in with your body to see how you're feeling. Okay, and now to break the rules kind of into parts. For a better sleep rule number 1, again, going to that consistency. So waking up at the same time, regardless of how we slept the night before. Okay, so even if we feel like it was a rough night, rather than staying in bed, trying to make up for that lost sleep, it's getting up at that same time and maybe moving elsewhere in the house. First thing in the morning too, getting that light exposure to kind of help with our body's internal clock again. So exposure for at least 30 minutes within 1 hour of wakening. So this could be going on a walk, sitting on your porch in the morning, having your coffee or tea or a glass of water. If the weather's not great, depending on where you're living, and maybe that's not an option, there are some light devices that you can try too that kind of give that artificial experience of being exposed to light. So there's ways to get creative with it as well if we're not always in a place where it's nice enough to go outside and walk. Especially being from Newfoundland, sometimes in the winter there's quite a bit of snow. So another sleep rule here too is giving yourself what we call like clear your head time or a worry time. So with this is really getting at that nighttime thinking that comes up, which of course, like I said before, like sometimes that's our first moment of peace throughout the day is when we're going to sleep and the rest of the world is quiet and our brain likes to be a little bit loud during that time. But by giving ourselves that worry time, maybe earlier in the evening, like 3 o'clock, 4, or it could be at lunchtime, you're kind of setting yourself a schedule of like, okay, I'm going to give myself 30 to 45 minutes to kind of think about all the things that I'm worrying about. And I'm either going to, make a plan about it, or I'll give myself that, set my timer and I'll give myself this time to worry about it now. And what this does is you can kind of, get it out of your head, or you can write it down too, which can be helpful. And then when you're in bed at night, you can remind yourself of, okay, I've already given you 40 minutes of my time today. I set my timer. I've already thought about this problem, like kind of go away. I put my time in about it. Or, at night, you can always be like, okay, tomorrow you're going to be on my worry schedule, whatever kind of comes up. And then you can write yourself a note by your bedside of like, okay, I'm going to worry about this tomorrow during that time. Now, this one is kind of easier said than done. Like if we could just wish away those thoughts, we would just do that, right? So it's getting into that practice of being like, okay, I'm going to give myself this time to worry about it. And just again, building that habit and that practice of kind of giving yourself a designated time for that worrying. For our third kind of rule is establishing something we call a buffer zone. So giving yourself 90 minutes before you're going to bed to kind of give yourself time to decompress from the day and relax. So during this time, again, we recommend that dim lighting. So turning off some of the overhead lighting, maybe having a couple of lamps on, and engaging in some activities that are enjoyable, but also relaxing. So if you're someone that gets, caught up in a really good book and you kind of have to keep going and you can't put it down, looking for a book or something else to read that is still enjoyable, but not overly engaging. So you can kind of close it and put it away when it's time to go to sleep. Same thing with if you're watching TV or anything, something that you want to be able to turn it off. We do recommend like no devices during this time as well. But I know sometimes people really like reading on their Kindles. So if there's a night mode, that's always a good alternative too. For our next sleep rule, try not to spend time in bed trying to sleep. Okay, so we say kind of the sleep effort is the enemy. So the harder we're trying to sleep, we're probably not going to sleep because we're thinking too much about sleeping. So if we're not able to fall asleep within 30 minutes, or if we're finding ourselves getting really frustrated in bed, we want to get up and have that experience elsewhere. And what we're doing with this again is strengthening that relationship between our bed and sleep. So if we're able to kind of move out all those frustrations or that wakefulness elsewhere, we're not going to pair our bed with that feeling of wakefulness anymore. Okay, so that's the one option, is kind of moving yourself out of the bed. Something else we can do when our brain is loud is going towards some relaxation techniques. So there's progressive muscle relaxation, deep breathing exercises. There's a whole bunch of them. I didn't include them all here, but I encourage you to, go onto YouTube because there's tons of them there. There's like really short ones for 5 minutes. There's some up to like 25 or even an hour. But these can be a really first line of defense, essentially. So if you're awake at night and you're unable to sleep, you can try one of these. And then if you're finding yourself still getting frustrated, then maybe moving to the getting out of bed and moving yourself elsewhere. Okay. And then lastly is about the sleep environment. Or there might be a few more after this, but our sleep environment too. So trying to keep it as cool as possible, again, to help with our body's internal clock. Try to have the room as dark as possible too. So there's tons of different options about this. There's eye mask, there's room darkening curtains. Some people like to have like earplugs in if their noise kind of disrupts them. And we recommend also completely removing TVs out of the bedroom and also turning your clocks away. Clock watching can be something a lot of people engage in. And what tends to happen with that is when they're awake throughout the night, they're looking and like, okay, it's 1 o'clock. Okay, now it's 2 o'clock. It's 4 o'clock. I'm not going to sleep, or I don't have that much time to fall asleep and I have to be up at such and such time. Those really kind of clock watching activities kind of contribute to that conditioned arousal state again. So if you still need the clock in the room, you can turn it behind or you can take it completely out of the room. Okay, so rules for napping. Again, with napping and with feeling like fatigue throughout the day, sometimes napping is what we need. And that's okay too, to like listen to our body in terms of what we need for naps. But if we're going to take our naps, we recommend keeping them for less than 20 minutes and no later than 3 p.m. So quick, short naps before 3 p.m. And then lastly, try not to stress about a poor night's sleep. Our bodies do know how to naturally kind of get into sleep. And, the effects of worrying about sleep are more impactful on our sleep than us not being able to sleep, essentially. Because if you think about a poor night of sleep, that means your next night, your sleep drive or your sleep pressure is going to be really strong. So trying to find ways to reassure yourself that, okay, like tomorrow my sleep will be better because my sleep drive is even stronger now. I have some additional resources. These are ones that kind of go through some of the aspects of cognitive behavioral therapy for insomnia. They're self-directed. I believe you can find them at Chapters or on Amazon. These are 2 really good books for that. And then lastly, I wanted to let you all know about a potential research opportunity if anyone is interested. My supervisor, Dr. Garland, has been working on developing an app made with cancer patients, for cancer patients. And it's a smartphone app called I Can Sleep. And what it is essentially the CBTI protocol adapted to an app form. And you kind of work your way through it. It's accessible to anyone in Canada who has been diagnosed with cancer. And we're, kind of at the earlier stages of testing out the app and looking to get some feedback on it. So if you're interested in participating and working your way through the program, you can go ahead and send an email to the I Can Sleep app at gmail.com. And and I can go back to any of the rules or additional resources if people would like to see those again. But that's everything I have for you.
Thank you, Catherine Ann, for all the feedback in regards to sleep health and fatigue management. There were some great tips. I definitely am taking away some tips on how I can personally improve my sleep. I found the concept of using sleep drive to your advantage and just doing the math, that concept very interesting. You did mention your number that came up was 1 a.m. But that doesn't sound very pleasant to me, Catherine, and I hope you're able to sleep before that time. But all jokes aside, just a reminder to the audience, if you have any questions, please be sure to enter it in the chat and we'll go through as many as possible. So a question we have here is, if we are exercising at night, is there a time when we should finish before sleeping?
Yeah, that's a really good question. So with exercising, it can be really helpful for that circadian rhythm in terms of having that normal exercise. But doing a intense or high impact exercise before sleep can actually make us feel more awake, I guess. So I guess it depends on what type of exercise you're doing, like light yoga before bed can be good. I wouldn't recommend going on like a long run. But to give it like a kind of cutoff time, you definitely want to make sure that it's well before that buffer zone. So for me, if I think about it, like my bedtime is 1 a.m. as we kind of guessed it through the presentation. And if I'm giving myself an hour and a half, so that's 11:30 to kind of wind down, I definitely don't want to be doing any exercising probably 3 hours before then. So again, it's all about probably the type of exercise you're doing. That's going to impact your sleep, but giving yourself more than enough time to kind of relax afterwards.
Thank you, Catherine.
Answers your question.
And another question here, how can patients effectively track their fatigue and sleep patterns to communicate with their healthcare team?
Well, that's a really good question. Well, there's a couple, there are tons of different like sleep diaries accessible online. So if you're looking to kind of monitor your sleep and be able to kind of go in and be like, look, like this is what my sleep is looking like. There's, I'm sure if you just search like consensus sleep diary on Google, there'd be some like printable PDFs. And that's largely what we use in therapy anyways, when we're going through like CBTI, but it's a great way to kind of track your sleep to see where your sleep is at. And then making note too of like maybe just giving a scale on like 0 to 10 as to where your fatigue is at that day could be something you add on the end. I will say like in sleep and sleep research, like sometimes it's often overlooked, but it's something all of us kind of do, and it plays a huge role with, especially within the cancer population, but also within the general population. And oftentimes, when we do go in to talk about our sleep difficulties, we're kind of given with, well, here's the sleep hygiene worksheet, or here's an information one pager of things we can do. But there's also specialists like CBTI therapists that specialize in that delivery. So if you are interested in pursuing that, asking your doctor for a referral to CBTI specialists can be helpful too.
Perfect. And on the topic of CBTI, we do have a question. What does cognitive behavioral therapy for insomnia actually look like? What does it involve?
So it's different for each individual, but the duration is different for each individual. The approach is similar. So it could be anywhere between 7 to 12 sessions. And cognitive behavioral therapy looks at our thoughts, feelings, and behaviors around sleep. So in this case, the behaviors we kind of got at in terms of, are we reading in bed? Are we thinking in bed? Are we sleeping in on weekends? That would be, kind of addressing those behaviors. Our feelings about sleep. Do we feel like if we have a poor night of sleep, we can't kind of do anything that we want to do the next day? Our beliefs about sleep. So again, that thinking if I don't sleep, then this might happen, or I'm not a good sleeper because of X, Y, and Z, or I need to be in bed for this long in order to sleep. So cognitive behavioral therapy for insomnia kind of looks at all those factors and makes some recommendations like for your unique needs, while also providing that prescribed time to bed and wake up time. So it's designed to be anywhere between 7 to 12 sessions. And again, it's different for each individual. And it's really driven based on kind of your sleep data and what your sleep looks like.
Perfect. And next, going back to relaying information to your doctor, how do I differentiate between general sleepiness versus fatigue? And at what point should I discuss this with my doctor?
Yeah, I'd say, if you're having questions about it, always just bring it up. If you're kind of on the fence of wondering, it might even be worth having that conversation because it doesn't hurt. And they might have other resources available for you too, depending on where you are and what they have available. In terms of differentiating between sleepiness and fatigue, that's actually quite challenging. So like with fatigue, it's not necessarily getting better, even though you're having adequate sleep. Whereas that sleepiness is that drive for, I need to sleep. Like I could barely keep my eyes open. So getting at those differences certainly can be tough, which is maybe where tracking that sleep might even be helpful to be like, oh, I'm really not sleeping, or I am having X amount of awakenings throughout the night, or it's taking me this long to fall asleep. Those are definitely some signs that, okay, maybe something else is going on here in terms of those sleep difficulties.
Thank you, Catherine. And in our previous sessions, one of the patients, a Hodgkin lymphoma cancer survivor, Jean, talked about how she experienced some shame bringing up some topics with her healthcare practitioner. But as you mentioned, I think it is best to, just to be safe, bring your concerns to your doctor. If anything, they'll just provide some reassurance.
Yeah, and that can be challenging though too, especially if you're used to maybe being dismissed or you feel like I have too many questions coming into this appointment. It can be really hard to, be like, okay, I only have this amount of time, like what question am I going to bring in? So it can be really hard to continue to advocate for yourself.
For sure. And I think we also talked about how writing down things is the best practice. And oftentimes patients will go into their appointments and forget what they wanted to discuss. So I would also encourage patients to write down so that they remember to bring this up.
Certainly.
And lastly, we'll just take one or two more questions. Is it harmful for me to take melatonin supplements to try and get better sleep?
Yeah, so melatonin is like a tricky one because our body naturally produces melatonin, right? But it often is something that is either recommended right away when people have their sleep difficulties, or because it's so readily accessible, we can just go out and get it at like a Shoppers or a Drug Mart or whatever it may be. So with melatonin, we usually say, like, depending again on the sleep difficulties, kind of just stop using it. Our body already knows how to produce it and will produce it. But it may just take some time adjusting and really kind of leaning back on timing that light exposure. So having that dim light in the evening and having that bright light in the morning. Definitely something worth kind of discussing with your doctor too, if that's something that was prescribed. And that's something in terms of sleep medication and melatonin, if that's stuff that you're on and interested in staying on or interested in coming off of, that can be done with the CBTI sleep therapist as well in collaboration with the doctor or pharmacist.
Perfect. Thank you, Catherine, for all of your feedback. And I just want to remind the audience, as this is the final day of the conference, please be sure to visit our resources tab in the internal conference environment to look through the various patient guides and resources. You do have the opportunity to download these resources and send them to your email. Additionally, please be sure to click on the survey tab as well, as we greatly appreciate your feedback and we'll be sure to use that for our upcoming conference next year. I would now like to direct the audience to attend our final session of the day titled Exercise and Wellness for Lymphoma Patients. Thank you, Catherine and Ann, for your great presentation, and I hope to see everyone there.
Thank you. Bye, everyone. It's nice being here.